Hello, everyone, and welcome back to another session with Dental Shadowers. Today, we have a very exciting session with Dr. Anamelechi, a pediatric dentist. Thank you so much, Dr. Anamelechi, for joining. And on that note, the floor is yours to take away.
It's a pleasure. Hi, everyone, and thank you so much for the invite, Dental Shadowers. I really hope to just share some knowledge, but also hear back from you all in terms of the things that you want to talk about, what you want to hear about, tell you a little bit about my journey, and then hopefully have some good questions from you all. At the end, you'll also get my contact information. So please reach out to me if you have questions or if there's anything that you may want me to talk more about that I started to talk about in this presentation. So we're going to get started. A little bit about me, okay? I'm from South Carolina. There might be a quiz on this at the end. I grew up on a farm. I have one sibling, a brother named Jason, and I'm a wife and a mom of two. If I'm not fixing teeth, helping mamas breastfeed, speak clear, teaching, or cleaning poopy bottoms, I also love Bikram yoga and Beyonce. So hopefully I want to see some hands up for anyone who may be a fan. So this journey to becoming a board certified pediatric dentist, I want to outline because sometimes we're not always looking at the little parts and pieces of what's going on. So most of you gone through your education, 12 years. I went to Duke University for undergrad, went to dental school at UNC Chapel Hill. Then I did my master's in public health and maternal and child health at UNC also. You'll hear a little bit more about that later. Then I did my pediatric dental residency program at St. Joe's in New Jersey. And give me a moment because I am using my phone and my computer to make sure I'm clear here. Then after that, if you didn't know, you have to take a written exam. So once you get done, I swore I would never take another test. And then there's a written exam. Okay, so lots more exams coming. And then now I've been out so long, we take a written exam next year. And so it continues. That's what I'm saying. It continues. It's not. All right. Moving on. So there was like an official definition of what is here.
Dr. Anamelechi, sorry to interrupt, but the microphone is a little quiet, or it's like maybe we can try to fix that. It could be like the placement of your phone.
Okay, give me 1 second. I have a huge technical difficulty. So give me 2 seconds to boot up. Are there any questions? I've only gone through 2 slides, but are there any questions about the initial 2 slides as I reboot?
Let me check for you. Oh, and I think you might have to mute on one of the other devices. I hear
Yeah, that's where I ran into the issue,
Oh,
and
okay.
it's the whole session.
No worries.
We'll be back up in just a second.
So if you guys have any questions, please leave it down below. I can read it out for you.
Okay, I'm back up on one end. Let me get back into my Zoom meeting. All right, and connecting again here. And just waiting for you to let me in.
There we go. It should work now.
Thank you. All right. right, we are.
So we got one question that says, why did you choose to get your master's after dental school?
Ooh, that's a good question. So I gotta get audio off. Give me a second. Okay, everyone, I'm back there. Can you hear me?
Yes, I can hear you. That's perfect.
Fantastic. All right. I think we're back on track. So to answer that question, I had a big, I would consider life-changing experience. My first year of undergrad at Duke, first summer of my undergrad at Duke, I had the opportunity to go to Ghana and study alternative medicine. And when I experienced that and really looked at disease and health in a completely different way, I was like, oh, this is something completely different than what I'm thinking about in terms of how I want to. I've known I wanted to be a dentist since I was in like elementary school. So this wasn't like this was something that was just kind of always there. And I have no dentists in my family. So I don't know. Great experience at pediatric dental office, I can say. And so when I started thinking about who was I and who I wanted to be as a dentist, I wanted to make sure that I was looking at health and disease in a way that would really help each individual person instead of this like global thing that everyone has to brush twice a day. Well, what if that doesn't work for a family? Or what if we have a family who, for religious reasons, doesn't believe in brushing? Like, what do I do? And so I wanted to learn how to relate to people on their level and not on my doctor level. And so by studying maternal and child health, it really just kind of opened my mind to a different way of thinking about dentistry as it relates to health. And I'll talk about that in a few minutes as we talk about how all these other things that, as we're looking at this definition of pediatric dentistry, all the other things that now I include as a part of my pediatric dental practice. So we look at our AAPD guidelines, and that's the American Academy of Pediatric Dentistry guidelines. And pediatric dentistry is, as you can read, an age-defined specialty that provides both primary and comprehensive preventive and therapeutic oral health care for infants and children through adolescence, including those with special needs, right? That's the textbook definition of what pediatric dentistry is. But what I also do is I help mamas breastfeed. My youngest patient was born last night. I'm seeing them tomorrow to release their tongue to help them breastfeed better. I opened a Thrive Center, and in that center, it's really an answer. It's a pediatric sleep center, and it's that answer to help kids sleep better. By our own experience of my son who had severe obstructive sleep disorder at 2, help kids feed better, help kids swallow better. And then we have an orthodontic component of our office. And so those are other things that like you may not think about when you think about pediatric dentistry and what's happening kind of in a daily life. So this journey then of becoming a board certified pediatric dentist to CEO, I wanted to throw in because it's different. It's a lot different. And so I did private practice as an associate as soon as I finished up in North Carolina. Then I moved to DC for love and was in private practice as an associate. Then I started at Children's National as an attending professor. And I'm still attending professor at Children's National and at Georgetown Law. Interestingly, in their law center, I actually help the law students write on behalf of kids with special challenges. And that's something that really piqued my interest, but also piqued my interest while I was studying at the School of Public Health. More moves in DC as I worked on the Hill, doing some oral health policy. I was the director of a nonprofit dental center. And then in 2014, I decided I want to do this on my own. I opened Children's Choice Pediatric Dentistry, opened our DC office in 2019, and then opened our Thrive Center, which is our kids sleep center in 2021. So those are all the things that have kind of happened, and I think are really cool because they've really shaped how I see myself as a pediatric dentist right now, and then how I see myself as a CEO, a woman-owned business. So the why, right? Because that has to be at the forefront of why are you doing this at all? And so dental decay is the most common preventable disease of childhood, 5 times more common than asthma, 51 million school hours missed per year. And this is old data. So I know because of the pandemic, we can't even account, right? Because they weren't even in school. So more just time missed because of dental decay, which is the most common preventable disease of childhood, right? I put it twice so I could read it, remind myself to read it again at the end, right? So something that can be prevented is causing all of these issues. I wanted to walk you through a really cool case study because again, this talks about my why and one of the things that very early on in my career I experienced. So this was 2016. October 1st, a child presents to the dental office with a facial swelling, uninsured. Total cost of the care, $450 for the treatment presented. And this was without insurance because the kid had no insurance. And this wasn't a presentation I did, this was at another dentist. October 5th, the child presents to an emergency room with the same facial swelling, but this time worse than October 1st. They decide to admit the child and start antibiotics. October 6th, the tooth was removed, the dental cost, anesthesia cost, hospital stay, all calculated. On October 7th, the child was released from the hospital and the total cost of care, $22,063. We went from a $450 procedure to a $22,063 procedure. That better be a tooth fairy that has a whole lot of extra coins for that tooth, right? Because it's insane. Like when I look at this and I see this all the time, I mean, I'm in the DMV where in Maryland, a kid died from a dental cavity. Like this is something I can help, right? That's my why. I'm a partner in the health of our kids and really helping to move the needle forward on how we can do better in helping our kids to have a life that continues to thrive. So, a typical day in my life. No day in my life is particularly typical. And I say that because one, I get bored really easily. So I don't like a typical day. But also, I wanted to show you in my little schedule what it looks like, as a family person and a CEO and a pediatric dentist. Okay. So this is typical day, not typical day, in my life as CEO. 5 a.m. start time, 6 a.m., 7:30. I'm not going to read all through it, but you see kind of all the facets of what happens in the day, right? And I do some podcast interviews, I do patient prep, and I start, my team gets here. Notice I arrive before my team. So some of these, I've been in practice now I've been in practice for 18 years, but next week my practice will be open for 7 years. And you think, oh my God, I own the space. Like I'm only here like 2 days a week or whatever. By looking at the schedule, you can see that there's a lot of work put into it. And also, I'm continuing to try to prepare for what I call my next life, right? My next career. So you'll see Leadership Lab, where I'm trying to develop myself as a leader and CEO. That's a continuous work in process. Social stuff, speaker stuff, coaching, really just trying to develop myself too as I develop my team. So that's a typical day when I'm in the office. Then on Fridays and some Thursdays, I'm going to the operating room. So the day starts about the same. I'm in the operating room from 8 to 4, back to the regular stuff. This is the day when I'm in my Thrive clinic. So typical day start, I'm in my Thrive clinic from 8 to 4, then back to the same stuff. those are all kind of different days. And the day I didn't include is a day like today, where I'm teaching at Children's National. It's a Tuesday, same start. The middle was a little different, where I have 8 awesome residents. And they are, on that day, we're doing orthodontics, craniofacial clinic, and our peds clinic. And I'm the attending faculty for that day. So it's a nice mix for me. It keeps me on my toes. My residents don't let me down and ask me a question that they try to stump me with every day, and I continue to learn because of that. So I love it because of that. So let your days be atypical when you get out into the dental world, because it really does make a difference to me in my life and my career. So I want to walk you through my office. So let me see if this works, okay? Fingers crossed, because technology has not been on my side so far. Oh yeah, it works. Okay, so this is my DC office. You're at the storefront right now. That's my son in the middle, Nicholas. I had a really cool guy kind of draft this up. The whole point of the office is not to feel like you're in a dental office. I'll be really honest with you. So we walk in, that's the front desk. We're kind of walking through, kind of where I'm sitting right now. This is our hygiene bay. Um, and of course, with pediatric dentistry, kind of have an open bay for positive reinforcement. And that works on some days, because remember, my days are atypical. So some days it works where all the kids are like, oh my God, look at that kid over there. They're doing so well. They're going to get a prize. I'm going to be good. And some days everyone's screaming. And that's how it is. But we really try to use this as positive reinforcement to see, where everything is. If you're looking at it directly, then on the left side, that's our patient care side. On the right side, that's our sterilization area. Moving forward. Come on, work for me. Yeah. All right, so we're coming down on the right side. That's an elevator that goes up to the second floor. We'll go upstairs in just a moment. On this right side over here, that's our X-ray, like our cool technology panoramic system. The panoramic system is, it's over here. Can't really see it as well. All right, let's see if we can walk up the stairs. Oh, I'm really good if we can walk up the stairs. So if we were to walk upstairs, you can see upstairs. Um, Walking upstairs is our patient care area. Those are our closed door areas. We also, on that segment, we have areas where you're able to, if we have a kid with special challenges that needs privacy, we have a kid with, that especially due to COVID, like a lot of parents, like, I don't want to sit down in that open area, then you can close the door. And so that's upstairs. We have a breastfeeding wing up there. We have a little patio up there. I wish you all could see it. I'll have to show some other pictures for you all. We have a little patio where you can sit out and just kind of hang out if you're in if your kid is in one of the treatment rooms and you just want to sit outside for a moment. But that's our space. And one day I'll learn how to get upstairs with us. I'm almost doing it. No, I'm not. All right. I'm going to close that down so we can move on. So when we talk about,
I think your camera actually just shut off somehow.
Sorry.
Perfect.
So when we talk about what kind of complaints patients have, that I was using the format that the DentalShadowers team gave me, and I was like, patient complaints or parent complaints? Because we have sometimes a little bit of both. That's what you deal with in pediatric dentistry. And so typical things, teething, atypical things, breastfeeding, which is the things that I do, wiggly teeth, shark teeth, which I pointed to are 2 rows of teeth growing in at the same time, because sharks have 2 rows of teeth. Caries pain, sleep issues, feeding issues, teeth that are not straight. And then of course, not a complaint, but like questions, because we'll have families, want to know, can you deal with a child with special challenges? And as you saw in that typical definition, we are the people to deal with that. So when we talk about our youngest patient being a day old, Our oldest patient is 35 years old, but has the IQ of a 2-year-old. So we deal with them like a 2-year-old, but with adult teeth, right? And so we take pride in that because the ability to still do that really makes us kind of special, a little multifaceted in how we operate on our daily basis. What kind of procedures do we perform? It really varies. I like to think of ourselves as the cosmetic dentist of pediatrics. And that's because people say, I mean, it's just baby teeth, right? And we're like, yeah, but they stay in until they're 13 years old. So we have to take care of those teeth. And so if we have teeth that are out of place or out of order, or in a few minutes, I'll show a case of they're just like not looking so good, we can save those. And we even make pediatric dentures, like little partials, literally, y'all, with like little teeth attached to them. And they are gorgeous. So we think of ourselves as cosmetic dentists of pediatrics. We do space maintainers. We're the keepers of the mouth until they're ready for braces. Frenectomies, which we'll talk about a little bit more, but that's the area that connects the tongue to the floor of the mouth, connects the lip to the top of the mouth. We do oral surgery. And in terms of that, it varies. Of course, in terms of what kind we do. Where I trained, we trained with the plastic surgery resident. So I can sew back on an ear, I can sew back on a nose, I can do a whole lot of things. And so we think of ourselves in that vantage point of being able to do so many different things because of our training. And so that oral surgery and head and neck surgery are two big things. We don't get too fancy in diagnostic tests and tools, but I have a light scalpel laser. That's a CO2 laser. I think it's pretty fancy and it really helps to define and really nicely finish when I do a frenectomy. It helps coagulate so that there's very minimal bleeding during the procedure because no parent really wants their kid to be handed back to breastfeed with a bleeding mouth. So it really helps. We have a panoramic machine, and interestingly, that machine also takes a full view, but also a side view, and also can take individual focal images of teeth. So that's pretty neat. The Nomad is what you see in the middle. That's the handheld X-ray device. And that device has kind of revolutionized the way we're able to take X-rays because generally we'd have that thing connect. You saw it actually when I was giving you the tour, connected to the wall. And so it gives us freedom and range of motion. Sleep studies are what we use a lot for my kids with potentially obstructive sleep disorders. And then we lean heavily on just instruments, right? We have a whole slew of pediatric instruments. There are actually instruments that they make that are smaller, head smaller, things like that, so we can get into the mouth of a child comfortably. The terms that we use in pediatric dentistry, some of the ones that stand out when I was thinking about this are patients with special challenges. And that covers a range of things, you all. So that could mean kids that just have sensory concerns. So, our office, we are loud, the music's on, the TV's on, we've got a million colors in here. And that's just too much for some kids. It is sensory overload. And so some of those kids, interestingly, we actually bring in from the back door and they go straight upstairs because they can't, that's not their experience, but we know how to deal with that. There's some kids that are on the other end in terms of just need more help. We have kids who are severely compromised, like I have a couple of kids who are waiting for heart transplants, like things like that. That's what we call our special challenges. We talk about minimally invasive dentistry, and the next term, SDF, is a part of that. But we really want to practice dentistry that doesn't just like need to be restorative dentistry. It doesn't have to be a tooth that comes out. We can save a tooth and be minimally in our restorative work, like conservative, honestly. And so SDF, which is silver diamond fluoride, has revolutionized how we approach our care. And so I'm going to show you a little bit about that. Now, this is something that gets me in trouble with my pediatrician sometimes, okay? Because the silver diamond fluoride, if you were to think about it, and you may not know this trajectory yet, but when we think of, we have a young kid, we don't want to take them to the hospital yet because they're under 3 and they may not have lung development yet or proper lung development yet. So we don't really want to take them to the OR under general anesthesia. So we have an option. Can we hold them until they can get proper, until we can take them to the OR, meaning they're developed enough? So we used to just use fluoride. Fluoride varnish works really well. It has 80 years of research. We know it works. We know it slows down the progression of cavities. Now we have something called silver diamine fluoride. And it's like fluoride on superpower because what it does is it actually stops, kills the bacteria that is on the tooth so that it potentially doesn't even get bigger. It doesn't even grow. That's the pro. The con, you see the black marks, the staining? The silver leaches to the bacteria and turns it dark. That's how we know it's working. And so sometimes, we'll maybe one of our pediatrician friends will send a kid over, and they'll say, yeah, can you treat this? And then they go back for their physical, and the kid ends up with comes back and their teeth are black, and the pediatrician's like, what did you do? And I'm like, that we had went through all the risk benefits and options, and the parent chose this. I don't see a lot of parents like in these pictures. I put these up because I wanted them to be more dramatic so you could see them. A lot of my parents won't accept anterior or front tooth silver diamond fluoride. They'll accept back tooth. They'll be like, you can't see it. We're going to accept that. Front tooth is a little harder, but it's something right in the middle of fluoride and restorative treatment that we're now using. So I wanted to share it. Nitrous oxide is huge. It's one of our main behavior management modalities. It's safe, it's effective, it's easy on, it's flavored in our office. I mean, you get like a 5 flavors. So kids will come in and like, I want the stuff. And I'm like, okay, we're gonna slow you down on the nitrous oxide. But it helps. And it really begins like when we talk about behavior management, that's one of the first things that we'll offer. Sedation, that's the next thing we'll offer. It's usually with a liquid medication. Sometimes I can cocktail them and to do what I need. So like if a kid has big cavities, I need to control pain. I need to make sure they are calm, all those things. And I'll pick a medication that I can mix to do all those things. Next step is general anesthesia. We're literally going to the operating room. I go to Children's National for that. Kid is fully asleep, do all their work at one time, wake them up, done. That's the pro. The con of that is our literature says 67% of kids that go under for general anesthesia go back. And really, it's because it's easy. Parents don't they don't really, it's like, oh, it's one and done. Oh, this is good. The kid didn't even cry. I didn't even have to go back for 5 visits. Like, this is great. And so I really, really in our office do a heavy oral management program for them to understand, like, we're only doing this once. There are definitely risks to general anesthesia. We want to make sure you understand what's going on. So that's it. Frankel score. Frankel score is a cool thing we do in the charts to say, if a kid was not so good, we don't really want to put that in the chart. Parents, they're always excited to see that their kid was terrible. So the Frankel score ranges from 4 to 0, 4 being the best, 0 being, we did not make it today. So that's one of our coding systems. And then failure to thrive. We talk about failure to thrive. It's one of the reasons why we call our center Thrive, but there can be several reasons. It could be abuse. It could be a poor dental care. I have actually reported families to Child Protective Services for poor dental care. They're not able to eat well because of maybe some oral restriction, things of that sort. So those are some terms we use in pediatric dentistry that may be different from what you may be used to. All right, so we're going to go into a couple of cases, but I'm not going to take too long because I still want to hear some questions from you all. So I started with pedo case, right? And I put these on here because I wanted you to see the stage of progression. When I was going through it, I was like, I should have showed them how I actually restore these. But I think it helps to go through and just talk about it. So, the first box, we see a white spot. That's early. ECC is early childhood caries. They will refer to us. And we typically try to hold off with that by doing some diet counseling, doing some fluoride varnish. Remember, I said that protects it and arrests the lesion. And so at that stage, it's not cavitated. There's no hole. We're just like, that's a warning sign. That's the white flag, as we call it. And you're like, something needs to slow down. You need to slow down on whatever's happening. Because then if we see them and they come back and we're at step 2, which are white spots, progressing to brown cavitation, we got to do something. And we tell the parent, if you don't stop, whatever it is where we're going to be. And for a child, this goes very quickly because the outer layer of a tooth, of a baby tooth, isn't very thick. So once it has that early white spot lesion, it's cracked the surface, and we know it could potentially go to that brown spot quickly. So looking at it, you can say, this is, what are we going to do? Fix it? Are we not? We start talking about options at that point. Next is that early aggressive childhood caries. And that's, it could range from a whole bunch of things. I'll be honest with you, a whole bunch of things that this could come from. I would say in our literature, 5% of it is actually genetic. 95% of it is diet. So sometimes we'll hear, oh, our family has weak teeth, such and such lost these at 4. We knew our child now is going to lose their front tooth at 4. Like, no, they don't have to. We just have to. And that's why age 1 is the recommended first dental visit. So we can get this kid in before they have all 20 teeth and get all the questions out before this happens. Because then we get to advanced stages, and the thing that you may see is this little like red lesion here. That's an abscess. That tooth gotta go. It's urgent. The bone isn't very thick. It could easily go up to the brain. It's gotta go. And so that's how we look at, what the typical things that we see on a daily basis in our restorative care. The other typical thing we see is trauma, a lot of trauma, because our kids are learning how to walk, they're learning how to ride their bikes, they're learning how to jump off of beds. And so trauma happens, and it happens quite often. And so it's interesting, until I had my 2 associates, I was the on-call trauma doctor for 6,000 patients. And so I would see, I'd get calls, oh, it's, 9 p.m. What is Johnny doing up? He's 2. Why is he up? He fell in the bathtub, or he was jumping on his bed, or didn't want to go to bed, and it happened. So in a typical case, when I get that call, I'm like, what could it be? Could it be this picture number 1, where the kid just chipped a tooth? All right, terrible. Maybe I don't have to go in tonight. I can see them tomorrow. Is it like the middle picture or middle radiograph where they completely avulsed a tooth? It's gone. All right. Then the tricky part is, and it's happened where, this kid, he's young. We know typically it should be a baby tooth, but at times parents don't know like what tooth was lost. Was it an adult tooth? Was it a baby tooth? So you have to find that out. A baby tooth, we're not going to put back in, right? We can't, because the adult tooth is growing under there. Okay. But an adult tooth, we have to get it in, and the maximum success time to get it in is within an hour. So we have to move, because if we get it in that time, we might be able to see. If we don't, it's a toss up. Or the trauma could be this third picture, which is like the ideal scenario. They bump their teeth, they may have moved them or pushed them in a way, but they can still bite normally. They could be a little wiggly. It's okay. We will watch for kind of the sequelae of what happens. So trauma is another big thing that we are experts in pediatric dentistry. And so, but when we talk about it, I was showing us the x-rays, and we talk about it, when you look at this picture on the left in the black box, you'll notice that there's this tooth coming in, and it looks real funky, right? And when you look over at the x-ray, you can also see there's a tooth that looks a little squished. Well, we take baby tooth trauma seriously, because what happened in this case is this kid bumped his tooth as a child with a baby tooth, bumped it and pushed it up into the gums. The baby tooth fell out normally, okay, fine, but the adult tooth was affected. And that's what happened to the adult tooth. And the reason being is because the adult tooth was still growing in a little sac, and the baby tooth got pushed into that sac, and it literally took off the face of the adult tooth. So that's why we take baby tooth trauma when parents say, oh, they just fell, do they need to see you? I'm like, yeah, because we need to prepare for what may be happening next in your child's mouth. And this is what could happen. And the teeth tell stories. Like, we can, without even seeing the x-ray, I could be like, and at what age did your child fall? Was it traumatic? Was it a big deal? Was there a lot of blood? Like I start backtracking, and the parents are like, oh yeah, I remember that time. I'm like, yeah, and that's what happened. So when we talk about which teeth are most likely, it's usually the front teeth, top teeth, then bottom teeth. Um, and so we know like if a child, and it's just because of how they fall, that usually it's the front top teeth that are most affected. Special considerations when we're talking about trauma. One is lack of cooperation. I mean, you have a little one, you may not be able to get x-rays, you may not be able to do any ideal treatment. And so we're sort of kind of picking out what's the best treatment that we can do. The psychological and emotional impact, for some kids, this is their first, this may be their first dental visit, and it was a trauma. Growth and development, where the kids are in their growth and development. The caregiver and family involvement is a huge determining factor in all the phases of treatment. And then we have to consider abuse. Because when we see things like that, we're like, okay, put the pieces of the puzzle together. Does it make sense or does it not? If it doesn't make sense, we have to report it. Other long-term effects, oral health effects, stress and pain, quality of life of the kid and child, of the child and family, the cost and time. And I'm actually in this next slide talk a little bit about that. Look at that for a minute. I think it's really cool. And it came from Jessica Lee, Dr. Lee, who is now the president of the American Academy of Pediatric Dentistry. She taught me, so I feel really cool because I was taught by one of the best. But when we talk about injury, emergency care, follow-up visits, subsequent long treatment, and long-term monitoring. You remember that 6-year-old that I was talking about that got bumped, and now that tooth is coming out in a not so great way. Well, he had injury. He might have some lasting memories of that injury. There was some immediate emergency care. There are going to be some indirect costs, which is time lost for the child and the caregiver, less than optimal dental experience because it's stressful. There are also direct costs, indirect costs for those follow-up visits. He's going to have multiple follow-up visits to get that tooth back to where it should be, which takes compliance, which takes good behavior, which takes family willingness to make those visits back and forth. So you can see like dental trauma is like, it seems so small, and especially with baby teeth, it seems so small, but it can lead to so many other things. My last case is a frenectomy. I'm gonna go back. All right, guys, give me a second. There we go. My last case is a frenectomy case. And so I think this is really cool because when you look at this before picture and think about this tiny string, right, that causes so much drama. This, the baby they couldn't feed. They were literally, the nipples of mother were bleeding, like she could not feed this child because literally the tongue was being pulled back into the bottom of the mouth. And so what the child was doing, no teeth, they were taking their top jaw and bottom jaw and using their bone to squeeze out milk. Imagine that. And so parent came in, she's like, I can't do this anymore. If we're gonna be on this breastfeeding journey, something has to happen. So we identify the issue, we resolve the issue. Kids doing well, right? And so these are like the feel goods, right? Because it's a lot of emotion. Oh my gosh, there's so much emotion. Sometimes we have new parents and they're just like, I don't know what to do. And we do something that seems very simple and it changes like the whole trajectory of what's happening and the ability that's so precious. So when we talk about tethered tissues, there's a lot that's happening throughout life. When we look at like in utero, we're talking about lip and tongue ties that form in that first trimester. There are lots of developments that happen born to feeding as an infant or baby. And I would say about 85 to 90% of the kids that I see are my baby babies. But when we decide to either, when it was missed as a baby or when they aren't having any breastfeeding concerns and we decide to do a monitored weight, then in toddler, as we become a toddler, we're still watching, right? We want to see, is feeding okay? Can they swallow okay? Are they progressing through all of their feeding landmarks or milestones? And these are all things you're like, why does a pediatric dentist have to know it? Because we have to know if we need to do something about it. And so when you talk about speech difficulties, things of that sort, there's no guarantee in the literature that a child that has an identified tongue or lip tie will have speech issues. There's a correlation. So we're always looking. And we're always looking, even so look, we look at this 50-year-old who has an untreated tongue tie and is having sleep issues, is having sleep obstructive issues, is having all these different things. So this is kind of the tethered tissue. Tethered tissues is also one of the terms that we use when we talk about a tongue tie or a lip tie. So those are my 3 cases. Here's my advice. Figure out your why. And this is not, you're not, maybe some of you are in dental school right now, maybe you aren't, or on your way. Wherever you are, figure out your why. Don't do it just for the money. You will earn it. You will. But if you're doing it just for the money, it's so easy to see. It's so easy to spot. And it's unfair to patients and families that we serve. I'll be honest with you. Find your uniqueness to you, right? Because you're going to use that. That's going to be your theme as you progress through school, as you form relationships with your patients, as you move along into whatever part of your career that you're going to be in. And then learn the people. Everyone's not the same, as you know, right? We say that, honor our differences. But are you actually willing to learn the differences? Are you actually willing to stand up and understand different feeding habits of people from different cultures? And then move that into why, how do we help them in their diet to make it a more oral or tooth-friendly diet? Are you willing to talk to people about what their concerns are and why they see that it's so hard? Are you able to look at a single parent and say, what I'm telling you to do is unrealistic? Then where can we meet in the middle? If you find that you're trying to stretch, if a family that's financially bound are trying to stretch their dollars, and of course they may buy food that may stretch as far as they can, but may not be as healthy. Where the lines? So are you willing to do all those things as you move into your next part of your career? Think about them, because these aren't the typicals, right? These are things that I found along the way that are important to understand, learn, and grow. My advice, more advice, the day you plant the seed is not the day you eat the fruit. It's a journey. There are so many facets, and like you saw that little roadmap that I, had up there in the beginning. There are so many twists and turns in that map. It is ridiculous. I'm here, right? And so I'm starting to see more and more every day the fruit of the seeds that were planted, the fruit of the seeds that my parents planted into me. I'm now starting to be able to see that, but you got to be patient. It's not going to happen overnight. I just paid my last student loan yesterday. I graduated in 2006. They're the fruits of the seeds that were planted. Join me. You'll see some of my journeys on our practice page. You'll see some cool cases on Thrive by Children's Choice. You get to learn a little bit more about me and my mommy journey and my dentist CEO journey on Mom Inspired Dentist Approved. But I really appreciate kind of this opportunity to talk with you all today. Really excited to hear what other questions you have. And I open the floor now for additional questions. Thank you all for your time today.
Thank you so much. That was extremely insightful. So we have a lot of questions actually in Ethan.
Oh gosh.
Alrighty, so I'm going to read out some questions from the viewers on the YouTube chat that they had submitted. So the first one is, when did you know you're ready to start opening and managing your own practice? Was it more of a financial reason, or did you feel that you had enough experience to begin? What are some signs?
Neither one of those. I've lived my life on dares. So I had a guidance counselor that told me I couldn't get into Duke. So I applied and I went. I was in an associate experience that was challenging. It was super challenging. And, I was like, I don't know if I don't know what I can do better, but I know I can do it the way that I want to do it. And that's what really pushed me to open my practice. I had no business experience. I walked into a bank asking for $500,000 without a business plan. Okay. So, after I got rejected on my first my first ask, and they were like, can you come back with an actual plan? You learn. And that's why I'm still learning. I'm still doing, at each phase, I find a new mentor, I find a new coach, I find someone that's going to help me continue to do more and have more impact. So it wasn't financially because we were young. I mean, the things that are hidden is we opened a practice. I got married in April. We opened a practice in July of that same year. A year later, I was pregnant with my first kid. We were in the practice 2014 up to 2019, then decided to open a second practice. It took a while to figure out things. My daughter was born in February of 2019. I got a call that next day that we were ready to build for the second practice, like we got permits. I said, let's start. We opened in July of 2019. And so it keeps going like that. And so we make decisions based on, when we feel things are right. Our second practice is in the neighborhood I live in. I've always wanted to be a neighborhood dentist. Super cool to see the people that, to live with the people the kids that I actually see. So no, those decisions weren't financial. And, every day I'm like, am I really ready? But I show up and here I am.
Awesome. So our next question that we had was, what are some tips on how to treat a patient with autism?
So we do a few things in our office. On our initial phone intake, we really try to figure out what works best for the child at home. So we'll have our kids, some of them have like physical therapists, occupational therapists. We ask them to come with them because sometimes they're doing the toothbrushing at home and they know how to make that approach. We ask, are there sounds that bother the child? Are there particular cue words that work well so that we can use them? There was a child, I distinctly remember, that used to only brush their teeth in one of those inflatable pools. We brought the inflatable pool to the dental office. We did their toothbrushing sitting in that inflatable pool. Like, you just have to know your kid, and the parents know their child best. You have to trust that and then kind of work up to whatever else. Some of my kids, like, you have to find out who they are, which is why I really appreciate that every child has their unique story. We also do what we call social stories for our kids with autism. And we now do them for any parent that asks, but it's almost like a little cartoon that shows, like, here's what Dr. Anamelechi looks like. Here's what her office looks like. You're going to walk down the hall. You're going to take an x-ray. And so they make a lot of those kind of social stories for kids for experiences. So they get to look at, the order of what things go in. The trick to that is pretty much every time we have to go in that order. Like, they have to walk down the same hall. They have to sit in the same chair. They have to do their x-rays next. You can't switch up the order because that's kind of how they know it. So autism has a huge spectrum, and you kind of just have to know, kind of get cues and hints of what to do and how it's working well in the home.
Awesome. Yep, that makes lots of sense. So our next question was, what advice do you have for pre-dental students deciding to get their master's degree before going into dental school?
So we do an internship program in our office. And so I have graduated 8 of my students are now in dental school. 2 have graduated. 1 is graduating from residency this year. And we've had this conversation a lot of times because I unless you need it, a gap year, like, just go apply dental school. That'd be my short answer. Unless you need it. And sometimes you need to take a break and just kind of regroup and get back on. Sometimes you need to boost your grades and you want to do a master's program to do that. It's okay as long as you get in there and you rock it out and you apply. Dental schools don't like to see these prolonged histories of, you know, what were you doing all during that time, or what was happening? Like, why did you do this master's? Like, you have to have an answer for that, and not just to like strengthen my dental school application. And so the master's programs can be good for particular things. And some, you know, when I talk to some students, I'm like, that's not necessary. Just go to dental school.
Got it. So actually, I'd skip this question. Someone was actually asking if your practice was open for pre-dental students to come in and shadow.
Yeah, we welcome pre-dental students to come and shadow. It's a full summer this summer. I guess as you know, things have opened up. We have currently 3 interns, and if you know, I'm always open to having people come and shadow. You know, some families get a little more ornery than others and don't want people standing there, and that's okay. It's fine. But I'm happy always to welcome students to the practice.
Awesome. So the next question is, when you treat a patient with silver diamine fluoride or some large procedure that you do commonly speak with parents or other practices that the patient goes to, who is part of the decision making?
So it could be the whole team. Now they could go talk to their pediatrician about it. I serve on a couple of boards where I go out and train pediatricians. And so I make sure I use that. I put that discussion in some of the literature so that they understand why we're doing it. Same thing with like lip and tongue ties and the importance of it, of releasing them if it helps. And so sometimes it's a decision just with the family and the provider, and we'll do it. Sometimes it's a decision with their entire healthcare community, and I have to talk about with them the pros and cons of what should be done.
Got it. So one student asks, how many frenectomy cases do you usually see? I'm not sure if that means today or weekly, but yeah.
So daily. So interestingly, tomorrow, I'm pretty excited. It's gonna keep me up late tonight, but we're doing our first community day because we have oh my gosh, our team, our team is huge. So we have all myofascial therapists on our team, but we also have external teams like speech language pathologists, infant body workers, lactation consultants, doulas. So for the first time, like all of these people refer to me to do the diagnosis and the release, or the surgical release. But some of them have never seen it. They don't know what happens after that, you know, all of those things. So tomorrow I just invited everybody in. And so I'm so thrilled because the lactation consultants and infant body workers are going to accompany their families to the visit tomorrow and sit through it, see the release, discuss, feel, talk. Like I'm just really excited about it. And we offer 3 scholarships to families who are not able to afford the procedure because the procedure is at a cost to do that. So sometimes finances may be a barrier to a child being able to breastfeed because they can't afford the procedure. So tomorrow we've given away 3 scholarships, each valued at $1,200 each. We're going to do this for our community. And I think we're going to do it. We may do it once a quarter, but on a typical day that I see frenectomies, I usually see about 6 to 7 on a day. Sometimes I'm doing frenectomies and restorative care, so of course there'll be less. But if I'm having a whole frenectomy day, maybe about 6 to 7 kids, and that ranges from the babies to my speech therapy kids to my teenagers.
Very cool. So another student asks, how do you see in utero tethered oral tissue?
So one of the cues of tethered tissues in utero are hiccups. And so the research has really correlated that quite a bit because what it means is a dysfunctional swallow. And if your tongue can't move, or if it can't move in the right swallowing mechanism, then you swallow too much air and then you hiccup. So it's one of the nice in utero things that we talk about and ask about. Sometimes, depending on where the baby is positioned, you can sort of see it, but we also look at some of those cues in utero too.
Got it. Awesome. So next question is, do you do full sedations in your offices? I know some pediatric dentists avoid full sedations because of the possible complications, like the kid in the Kansas who had passed away after an appointment recently.
I do, but I do it with a licensed medical or MD anesthesiologist. So I do some cocktails on my own. The cocktails that I do are mixed are ones that are basically, we have 3 levels to sedation. It's on the minimal level of sedation. If I'm going to do an IV sedation, it's going to be with my medical anesthesiologist in my office as a partner. If I have a kid, and that's a healthy kid. If I have a kid that's not healthy or a very long procedure, we're going to the hospital.
Awesome. No, I believe that is all the questions that we have in the chat currently.
Thank you so much, Dr. Anamelechi. That was an amazing session. We were honored to have you. Very informative. Thank you so much. If you guys have any questions, please make sure to check out her Instagram. And for those who are looking for the quiz, you can find that in our link tree or our group me chat. But once again, Dr. Anamelechi, thank you so much for joining. And on that note, I hope everyone has a great rest of their day.
Take care, everyone. Bye.